Okay.
So this is
Okay, so after that, an interesting question and answer round and valuable suggestions from our chairpersons, we'll now move ahead with the large group activity, which will be focused on the theme of this conference, that is, incorporating patient safety in current curriculum. For this, I would request our chairpersons to kindly introduce and invite our facilitators, Dr. Anshu and Dr. Munira, in the large group activity.
It's my pleasure to invite Dr. Anshu, who is the Director Professor of Pathology at Mahatma Gandhi Institute of Medical Sciences, Sevagram. She has been the President of Academy of Health Professions Educators 2022, Member Board of Directors, Network Towards Unity for Health, representing Southeast Asia, Global Faculty for Famer Institute, Philadelphia, Global Faculty for East Africa, Famer. She has received Commonwealth Academic Staff Fellowship, Famer Fellowship, DBT Clinical Fellowship, and IFME from Famer. She is a faculty member for all 4 regional Famer institutes in India, has numerous publications, contributed 30 chapters in various books, and what is not written here is that she is co-editor of one of our books on assessment.
But I put that there, they forgot.
And I also welcome Dr. Munira Hirkani, who is additional professor of physiology at CHGS Medical College and KEM Hospital, Mumbai. She is a faculty member of FAMER, co-convener NMC Basic Course on Medical Education, member of the expert group on early clinical exposure, I suppose the module that was written, task force member assessment and blueprinting at Maharashtra University of Health Sciences. She has received GSMC FAMER Fellowship in 2010 and contributed chapters to various medical education books, has numerous publications in national and international journals. So I invite Anshu and Munira to please conduct the next session.
So good afternoon, everybody. Both Munira and I have been invited by the organizers to conduct this large group session, interactive session. And since we are a health professions education conference, we thought that it is important that we demonstrate the large group methods that we talk about in practice. So from 2012, when Dr. Chacko invited us to do the first large group interactive session, I have been lucky to be associated with all of them. I think this is the 10th year I'm doing it. And every year is a different challenge because the settings change, and this year our challenge was that we had fixed seating. So we have experimented with different methods each time, and we hope you carry back this and try and apply. So this year we're trying something different, and I hope technology helps us, supports us, yeah. So I'd like to start with a story. In 1995, Sridevi, who was the top reigning actress, her mother, Mrs. Rajeshwari Ayyappan, she was diagnosed with a brain tumor. And since she could afford the best treatment in the world, her mother and she flew to New York to Memorial Sloan Kettering Hospital, where she was supposed to be operated. Now, it happened that the neurosurgeon who was operating, was expecting an Indian patient. There was a mix-up because all Indian patients apparently look alike to them. And instead of operating the left lobe where the glioma was there, he opened up and operated the right lobe, which was the normal brain. After which her mother lost her memory. She could not recognize anybody. The surgeon, of course, was fired, and the correct surgery was done, but by then she completely lost most of her memory, and she slowly passed away after a few days. So this is something which can happen in the world's best hospital. Let's try and see what happens in the Indian context. And this is not going to be a lecture, so we want you to open up your smartphones. You can either use the QR code there, or you can go to menti.com. The code is on top of the screen.
Please continue.
So the code is 82269564 and the QR code is there for you. And that keep calm is for me if technology fails. So are you all on this, have you all logged in? Should I repeat the code again? 82269564.
If anyone is facing any issues, just raise your hand. And
What
we'll
happened
see
to
if
this
we can
technology? Yeah.
help. All good. Keep calm.
Right? So can we proceed?
Yeah. So a very good afternoon to all of you present here. Let's start having the fun. So are we ready? Very simple things for you. We'll close the floating panels. Yeah. So this is the first response that we request you all to think of. Do you think errors are common in the Indian hospitals? Now, whatever we are thinking of is moving to our context and our country where we are practicing in. So let's look at the responses that we received from you. We'll wait for a few seconds more. We'll move it down. Move it down. Down.
Which one?
Wait.
Click one.
Give.
Okay, one second.
Yeah. Hide the video panel. Meeting panel. You will know how many people have voted.
It's okay. That's okay. We can see it here. That's it. Huh? I can if I want to.
So if we look at the numbers, they are rising, and yes, we all think that errors are common in Indian hospitals. And of course, that's what we all have learned with our experience. So, moving on to the next question and responses that we request from you all is think of your own discipline, your own work environment, and list out the most common errors that you encounter in your discipline, in your day-to-day practice. You can type out your responses. We'll give you 1 or 2 minutes. You can think about it, type down as many responses as you want. So here are your responses coming up on the screen for all of us. What we find most common is miscommunication, mismatch of samples. I think that's related to identification, errors in medication, apathy, administration of the wrong medication. We have medical errors, a very broad encompassing term. Communication related to medication, prescription errors, maybe wrong dose or drug is given. We again have drug errors, communication showing that that's one important aspect. We are talking about the other disciplines also where maybe by an error or alternate tooth has been extracted. Transcription errors in lab reporting, improper collection of sample, improper dose, maybe a wrong instrument has been used, maybe the error is because of late or wrong diagnosis, medication errors again, Prescription errors, and I am sure this is the pharmacologist sitting out here. Surgical errors, or it could be dosage errors. I see something called as clerical errors here also. Lack of accountability, mixed up teeth, sterilization issues, wrong diagnosis, or overcorrection or over-treatment. The commonest that we see is the improper hand washing. I think there has been a lot of literature on this, and we had this discussion also about how infection control is important, and that could be the commonest medical error. Underreporting of errors. That's something that we need to look at, and I think Dr. Pandya had talked about how we can minimize and how we can ensure that there is a system in place for reporting errors. Pre-analytical errors, prescribing antibiotics even when they are not required, so drugs when not required, incorrectly written prescriptions. I think many of these are something that we can think of at the undergraduate level also. Cervical perforation in primary tooth during RCT, documentation error, interpretation errors, wrong identification of patients like the story that Anshu had just shared with us. Wrong route of administration of drugs. Poor hygiene of the instruments. Missed patient reference or documentation in the wrong files. I think we have some things which are coming up more commonly, and I think communication and prescription is something that is featuring repeatedly. Along with that is the sampling errors and wrong labeling. Poor handing over between duties. So at the end of duties, the transfer. That's something again that we need to think of, and that's very common. Lacunae in post-operative care. Falls while ambulation training. Again, something that we can prevent and we can take care of. Lack of maintaining quality assurance in the lab. Hospital acquired infections. Wrong labeling on vials, use of expired syringe, miscommunication, machine related errors, venous thromboembolism which is not prevented.
The list will not stop.
The list is endless. I think each and every discipline has different areas and different things that will come up as a medical error. Electric burns during use of cautery. Yes. So thank you so much for contributing all your thoughts and sharing with us what is common in your own discipline. Let's think about something more on this. Let's think about patient safety and its place in our curriculum. Do you think patient safety is adequately represented in our present curriculum? We can see the flying dots coming in. This can create bias.
Everybody's got their own conviction.
But I'm sure you all are, strong enough to stick to your own thoughts. So currently we have a revised curriculum since 2019. We have the competency-based medical education, and my next few questions are focused more on the undergraduate curriculum. So teaching in the undergraduate areas. So yes, we can see a large mass which is saying no, and maybe there are a few number of maybes. Okay, So we are not sure, somewhere there is something being taught, but maybe not explicitly. Thank you so much. Let's move on to the next question for you all. What do you think? Who is responsible for teaching patient safety related content in the curriculum? Who is responsible?
At the moment, who's
All departments, each and every department.
in the present curriculum, are they all teaching? This is the question.
Question is about responsibility. So yes, we are all responsible, but maybe it's something like that story of 4 people. Anybody, somebody, nobody, everybody. So it's like everybody knows that patient safety has to be taught in the curriculum, and we think somebody is going to do it, but anybody could have done it, but nobody has actually done it.
You want to scroll it.
So yes, it's across all departments. Yes, pharmacology is responsible for doing it.
Shove the responsibility.
Community medicine. We have the IQAC cell, medicine department. So it's like we can fix the responsibility on someone, somebody.
I'm happy somebody did not say dean.
They have come up with the IQAC cell, and I'm sure.
There is Dean Academics.
Yes.
MS Office is not.
Hospital management, all clinicians, top management, doctors, nurses, all health professionals. I like this term. All health professionals are responsible. Medical education department, we all are medical educationists and health profession educationists. Again, we have biochemistry, pathology, all clinical departments. That's great. Absolutely.
NMC.
It's good, no one has said NMC and other councils. Okay. So ideally it's each one of us who is responsible in our own way, in our own setting, in our own practice that we can do. So I think I will take something here, what Tejinder sir has mentioned, that he talked about the curriculum is expanding. We have no place for adding anything new without removing something. So we are unlikely to get any more space in our curriculum, any more free time to include patient safety as a separate module or as a certificate course. So we need to identify learning opportunities within our own existing curriculum. So where all do you find time and an opportunity to teach that? So you have to seize the moment. So now think about your own specialty and which are the areas related to patient safety that you can teach within your own specialty. The areas. So we are looking more at the topics which can be taught regarding or in alignment with patient safety rather than how it is being taught. We are looking at what can be taught. So we have these pharmacovigilance, sample collection, diagnosis or clinical competence, communication, attitudes, ethics, treatment planning. So at the center is more about collection of sample, identification of sample, proper communication, which includes verbal as well as the documentation, medication safety, prescription writing, reporting of adverse effects, reading or interpreting the diagnostic reports correctly, in blood grouping and blood banking, there are a lot of errors that can happen which are critical. and all the other responses are out here for you to see. Someone has written handwriting. So maybe what we mean is clarity in the documentation, or even using computerized or digital technology for clarity. You want to add something, Anshu, out here?
I'm seeing everybody's responsibility here.
Yes. So there are different areas which we can cater to, because we are experts in our own field, and each one of us has some role in patient safety, whether it's on the front line with the patients, or maybe as leaders, or maybe supporting the clinicians or the healthcare. Okay, thank you again.
Consider patient safety in the context of multidisciplinary teaching. It's not one department's job. And so if you want to start small, I think identify like-minded colleagues in other departments. That's important, and every little effort will add up to it. So what you can do is try a mapping exercise to identify patient safety content within the existing curriculum. That will help, because we're already doing different things. Say, for example, I'm giving an example here. You are teaching ethics, and you already are teaching patient autonomy. So can you add in some contexts which are related to patient safety? Say, for example, if something went wrong in a surgery, do students or do doctors have the honesty to own up to it and tell the patient that this is what went wrong? Do they have that kind of integrity? So this is a potential safety learning issue which can be done when you are teaching autonomy. Change the context a little, tweak the context a little. And you can teach it in a lecture, but there are better methods of teaching it. You can use it as an OSCE. Say, for example, you have a setting where a post-op patient is there who was promised laparoscopic surgery, and he asks you, why is my scar big? What happened? Will you tell him what happened in the surgery, why you abandoned the laparoscopy and had to do a bigger surgery, why the scar is bigger? So things like that, you have to be a little creative and see where you can include different contexts to teach these issues. But having said that, I will remember what all of you have been saying, that as a teacher, you are an important role model, whether you like it or not. If you are going to say that own up to the patient, and the students are seeing you, that you are brushing things under the carpet, that you are hiding things yourself, it doesn't work. We have a hidden curriculum here. So if you are expecting students to show some kind of integrity, show it yourself first. And as Himanshu said, we treat medicine as a perfect science. It is not a perfect science. This is a system where errors are bound to happen. And what is important is to model, at least have the guts to say, I don't know, to your students, so that they know that nobody is perfect. And at least they have the courage to say that this is my limit of competence, and this is where I need help. So you are role modeling it for people when you say that you're the perfect person who has answers to everything. Nobody in the world is like that. So these are little lessons which go a long way. We talked about just take one example, maybe we're talking about patient identification. You need to reinforce the message again and again. Say, for example, you're in obstetrics or you're in nursing. Students need to be told somewhere on the rounds or elsewhere, how is it that the right baby reaches the right mother, that there's no mix-up? What are the procedures? What are the processes which happen there? If I am in pathology or I am in blood bank or in surgery, I want to know that how does the person ensure that the correct blood group is blood type is reaching this particular patient? What are the checks and balances in place? So you have to find your context with the same principle, and find spaces within your setting to deliver these messages again and again. So these are certain areas which the International Patient Safety Goals have recommended to be included in the undergraduate curriculum, and I want you to rank them in what you think is the order of importance according to you. So identify patients correctly, improve effective communication. We talked about handovers, talking to nurses, to the non-teaching staff who work there. So, which do you think are important? And this is according to you. Side effects of drugs, healthcare associated infections, how do you ensure safe surgery, how much do you communicate to patients, do you tell them what the risks involved are? Every specialty has its own issues. So these are areas which need to be mentioned in the, at least students need to be exposed to all of these in the curriculum. And the sad part is all of us as doctors know the importance of hand washing, we know the importance of antibiotic resistance, and still we do the opposite things. So knowing is not enough, we need to demonstrate it in practice. That's another issue. So suddenly communication, improving effective communication is where I think, because we can intervene more. So just change the different contexts here in effective communication. It's not just about breaking bad news, but also how you hand over a job to someone, verbal communication, written communication, all of that becomes important. How you write your prescriptions. And yes, this is another area. So moving on, what are the teaching and learning methods which you think would work for undergraduates to reinforce these concepts of patient safety? We heard a lot of wonderful things, and all the ideas which came up from the talks preceding this. Yes, Mahalakshmi's audit was an excellent example of how you can, with a little bit of creativity, introduce students to all of this. In the NHS, I think every postgraduate student needs to do audits. We have not yet made it mandatory. So when you're saying direct observation, remember observation should be followed by a debrief, and that is important there. Role plays, yes, but again role plays followed by a debrief, otherwise it becomes just another drama. Be careful of how you're using something, because a role play done badly can carry the wrong message. Right? So, has anybody written the student doctor program which the NMC is talking about? So, you are talking about students shadowing the doctors, following a unit. So, that's an excellent opportunity here for you to ensure that there are several teaching moments on the rounds. So that is where the students can actually see how the system works, and that is something you can do here. Yeah, somebody's written here critical incident analysis. Now, it's important for us to know who the habitual offenders are, and I don't know, in the West, it goes into your references and transcripts that this person has some problem with integrity. Here we write good for everybody. So somewhere there has to be a record of people who are unprofessional. They will need further counseling or further identification. We don't do that in this country. So people who are, these things have to be reported, recorded in the student's assessment. So yes, early clinical exposure is there. So you've given us a number of different ways, and all of this can work. But each of these have to be planned properly with the objectives in mind. Keep that curricular triangle in mind. What is the objective you're trying to attain? Which method you're choosing? Does it justify that? And will the assessment also be conducted? So you can also use scenarios, and I put up the scenario. Should I read it aloud, or will you read it yourself? So take some time. So the point I'm trying to make with this scenario is, depending upon the level of the learner, you can make the scenario a little more complex. So here, this could be used to talk about pneumonia, it could be used to talk about the pharmacotherapy, or you can tell them that yes, there are times when the hospital system is busy, there are times when the seniors are unavailable, there is nobody to look after, or is it a system error where the floor was wet, there was no light there. So everything doesn't depend only on human error, there is a system in place, and how all of this in its entire complexity can, so use this scenario as a discussion point or a trigger to initiate thinking in the students. So the ACGME competencies talk about these 6 different competencies. We have adopted most of this in the Indian medical graduate roles. However, there's a little bit of practice-based learning and improvement. We have included it in some form in the lifelong learning, but systems-based practice, as everybody has mentioned since morning, is missing. This needs to be incorporated in some way into our system. And as Sanjay said, this is my favorite book, Atul Gawade's The Checklist Manifesto, and he says, one essential characteristic of modern life is that we all depend on systems, on assemblages of people or technologies or both, and among our most profound difficulties is making them work. I recommend this book for reading, not only for you but for your undergraduates as well, because there are lovely stories, and use those stories to initiate discussions, to initiate conversations around what we can do and help people lose less lives. So what strategies can be used to teach system-based practice? We have heard a few. Any other ideas, any brilliant innovations here? To expose the student to the system of how people in different professions work together. Clinical audit, student doctor, the clerkship, and the interprofessional education. Teach interprofessional education, yes. So when you have nurses and doctors and physiotherapists working together, students learn from each other, whether it is in the skills lab, whether it is in the wards, all of this help. So shadowing a patient, hospital rounds, yeah, mock drills really can be used here. So mock drills where you suddenly change the context and create an emergency situation, that will work. Collaborative practices, hands-on, yes. We cannot allow undergraduates to actually treat patients, but at least let them get a feel of what is going on.
Participate in grand clinical rounds.
So the grand rounds and discussions, simulations. So there is no, there's no end to this. You use your creativity and think of what you want to do and get your multidisciplinary team together, and then you can create, ensure that every student, I wanted to talk about Himanshu saying that one MBBS student who came to you. I think every student should get it. Why only one student?
She is going to be a peer.
Yeah, so I said every student must go through this system that he went through. So the student doctor method is important here.
So one of the methods could be peer teaching also.
Yes, so all of these showing movie clips and all, everything here is relevant. So you know what strategies you can use. And Himanshu talked about the Swiss cheese model. We don't have Swiss cheese in India, but still these cheese slices can be compared to different barriers or layers of protection. So what happens here is that one person might miss or make a mistake, but if the other person can catch it, they don't slip through the holes here. So if this, layer after layer everybody makes the same mistake, then you lose the patient. So that is designing a safety culture or a safety procedure. Now the problem is each of us prepares SOPs with such difficulty, and these SOPs are all locked up in the HOD's cupboard. It comes out only during the inspections, and nobody's even allowed to touch it or read it. So I don't know where we are going to use all of these checklists and all of that. But the problem with us is we are perfect on paper. When it comes to processes, none of us do something. So only the IPC people, it's their responsibility for the papers, right? I agree with that. Okay. So now, does NMC emphasize teaching and learning safety issues enough? You put the responsibility on them. My God. Yes, no, yes. So which are the criteria we are talking about guidelines in NMC? What do they ask you? Head counts? Furniture counts? Room sizes? Huh?
Upload your degree every year.
Upload your degree every year, but do they talk about any of these issues?
It's documented. The global competencies as a clinician does mention that awareness or knowledge about these policies which are related to patient safety is important, and participation in any measures which will promote patient safety. It's mentioned, but it doesn't translate to any disciplines or any concrete plan of implementation.
Right? And okay. So next question. We have different accreditation criteria. In India, you have NAC, you have NABH, you have accreditation of the ethics committees. So which aspects of patient safety do you remember from the accreditation criteria? You have filled lots of forms. So what specifically do they ask you in terms of patient safety? In any of these guidelines? Okay, staff training, doctor-patient ratios.
Consent.
Nobody asks us how many hours the doctors work, whether they get fatigued, whether you're understaffed, how many hours the residents work. Infection control is asked, yes. NABH, what in NABH? I want to know, what do they ask in NABH? Medical audit, okay.
Nurse-patient ratio.
Okay. IQAC checklist for what? What in the NAC criteria asks you about patient safety? NAC nothing? NABH asks about antibiotic resistance?
Yeah, NABH asks about infection control. There are KPIs, key performance indicators.
Yes.
They have all those key.
Right, so NABH has some of it and NAC doesn't have too much. Yeah. Right, and the Lakshya has come up here also. Pharmacovigilance.
Documentation.
And patient adverse effects. So it's, okay, so this is somewhat in NABH, nothing in the others. NAC doesn't ask you whether you're teaching this or not. Okay, so last, let's come to what about assessment. How can you assess undergraduates? OSCE, okay. Multi-source feedback. Checklist-based assessment, workplace-based assessment, simulations. Yeah, so in your scenarios in OSCE, you can have specific context, like somebody is taking a consent for an emergency surgery. Does he ask what is the last meal that you have had? And if the simulated patient is taught to say, I don't remember, then how does the patient, how does the student respond? So, and does that person explain risks of having had food before a surgery? So,
With also
things like
theory
that.
questions mentioned,
Yeah, I'll come to that. Yeah.
clinical scenarios.
So you can ask these questions in almost every assessment format. In Vivas, you can give them hypothetical situations. For a simple example, maybe if there is a long answer question like this, where a medical superintendent discovers several cases of wrong medicines or wrong dosages being dispensed by the hospital pharmacy, and he sees that this is because of illegible handwriting by doctors and maybe the prescriptions were wrong. What can be done to ensure that these incidents do not occur again? So does the student understand how this can be corrected? So that is one way. It might not be perfect. And I've just put an MCQ. This is not a perfect MCQ for a summative examination. The reason, just read it first. So the reason I put this out is not for assessment, but to say that the answer is pretty clear. You don't, that is not my purpose here. The purpose is we are working in a culture of hierarchy where nurses are not allowed to speak to students, to doctors. They're scared. So in that situation, are we teaching assertiveness wherever patient safety is required? So that is the context I'm talking about in this case. So I'd like to end by saying that coming to Lucknow is not always a pleasant experience for me. There's always a tug in my heart because 24 years ago in another hospital in the city, I lost my father after a 1 month period where he was in a coma. I donated my kidney, and I don't know what went wrong, but he slipped into a coma, and I was never given a reason for what happened. There were people who said that they lost 5 patients in the same ward the same day. Some people attributed it to the air conditioners in the ward, probably having some kind of infection, which led to all of the patients ending up with pneumonia. Other people say that I was told that he aspirated something while drinking water, and people who were inside the OT say that the HLA matching was not done, and therefore the transplant failed. 24 years since that winter, again it was November, I still don't have answers. So for me, patient safety is not another wave of moral panic. Patient safety matters when it happens to you. It's something I cannot take very casually. We are in an era where we are promising people 1 medical college per district. We don't know how many faculty we have. We don't know about the quality of these colleges. And we have a very porous selection system. We know what happened with NEET this year. And only the rich are now allowed to get into medical schools. In this background, where will patient safety lie? Where are our ethics going to be? Is something that I worry about, and I worry about it a lot. Thank you very much.
Thank you.
A big thank you to our facilitators. I would like to request the chairpersons to please come forward and felicitate our speakers for their insightful addresses now. I would first request Dr. Himanshu Pandya to kindly come forward and receive a token of appreciation for his enthralling talk. Huge round of applause from the audience, please. I would request Dr. Thomas Chacko to kindly come forward and receive his memento and certificate from our chairpersons. May I now request Dr. Mahalakshmi to kindly come forward and accept a token of appreciation for a brilliant lecture. I would now request our facilitators, Dr. Munira and Dr. Anshu, to kindly come forward and receive the memento and the certificate from our chairpersons for their valuable contribution in the large group activity. Let's show some gratitude with a big round of applause for them. I would humbly request the chairpersons to please stay back, and I would request Dr. Nilmara Lei Rege to kindly come forward and felicitate our speakers for their valuable contribution in today's session as the chair. A huge round of applause for our chairpersons, please. Dr. Tejendra and Dr. Ananthakrishnan. Thank you, sir. Thank you, ma'am. Indeed, a beautiful symposium it was. So we'll now break for lunch. The lunch is being served on the lawns of the college building. So please proceed for the lunch. And I would request the resource persons, the resource faculty, to join us for the lunch venue on this floor itself. So we'll reconvene at sharp 2 p.m. for the next session. Till then, enjoy your lunch. Thank you.
भाई अभी ये इसमें कैसे लगेगा?
आपको पीपीटी जूम के थ्रू शेयर करेंगे।
जूम में क्या होता है जब आप प्रेजेंटर व्यू लोगे ना तो वो सारा वहाँ दिखेगा, वो तो दिखाना नहीं है ना।
बट सर हमारा भी कार्ड से आगे जो है यहाँ पे मीटिंग दो रूम्स में चली और 2 पर्सन बाहर से।
हाँ
अगर हम आपका लगा देते हैं तब भी हमें उनको दिखाने के लिए जूम यूज़ करना पड़ेगा।
नहीं, पर यही तो वो बोली अनुजा कहाँ है? यही तो वो बोली, नीमा भी बोली कि हो गया।